Hi, good evening to everybody, and thank you for joining today's Nivarana's Public Health Forum. For those of you who are hearing about Nivarana for the first time, Nivarana is a public health advocacy and information platform which was started in 2022. We aim to bridge the gap between public and public health by making complex information accessible and easy to understand. And we wish to empower people with the right information with the hope that more people would begin to be bothered by the public health practices in the country, understand what is lacking, and ultimately demand a change. Public Health Forum is one of our initiatives where we have solution oriented discussions of problems with experts in a panel and in the audience. Today, we are going to talk about a very important issue, which is end of life care and advanced care planning. And experts in the panel today will shed light on end of life care, difference in ICU and home based care, how we can create an advanced care plan, and how it can help in reducing suffering in our final days. And to discuss this, we have five speakers today with us. Dr. Roop, who will be joining soon, is a neurologist who works in Mumbai and is one of the leading voices in the country when it comes to advanced care planning and advanced medical directives. We have Smriti, who is the head of strategic programs and partnership at Pallium India and the head of WHO Collaborating Center for Training and Policy on Access to Pain Relief. We have Dr. Rajni, who is a pulmonologist and a palliative medicine specialist from Bangalore, and she works very closely with patients who are in their final days in the hospital. We have Dhwani, who is a lawyer and the legal expert when it comes to advanced care planning in India, and she's also the co-founder for Witty Center for Legal Policy. And finally, we have Urvita, who is a clinical psychologist and a researcher in Sangat, and today she'll be speaking as a caregiver. My name is Parth. I'm a community physician, a public health researcher, and the founder of Nivarana, and I'll be moderating today's discussion. I request all participants to please share their question in the chat box in Zoom or YouTube, wherever you have joined us, and we'll take those questions up at the end. Those who have joined us at Zoom can also raise their hands, and we can give them the opportunity to then unmute themselves and then ask their questions directly. So without further ado, not a very exciting topic to talk about, but there are so many people who have joined us. Some people have joined us at 6 o'clock, half an hour in advance. Death and dying. Today, that's what we're going to talk about. So I'll start with, I'll just check once again if Dr. Roop has joined us. Okay, he hasn't. So I'll start with Smriti then. Smriti, we often talk about life-limiting illnesses and end-of-life care and palliative care, but these are very confusing terms, and often people confuse end-of-life care, palliative care. So can you start by explaining to us what are life-limiting illnesses, and then what role does palliative care especially play in this domain of healthcare?
Thanks, Parth, and hello, everyone. Thank you all for joining us. I disagree with Parth. This is an exciting topic. Yeah, I think that's proven by the number of people in this room with us. Okay, so life limiting, I think I'll start by saying that palliative care, as it originated in the West, did primarily also deal with advanced terminal illnesses and end-of-life care. But in settings like ours, in lower middle-income countries, the net that we cast, sorry, in who is eligible for palliative care is much wider, simply because disease-specific treatment does not reach people in time or adequately, or sometimes it just becomes inaffordable after a while. And so we find people being expelled from the medical system. And these are also folks that would benefit from us reaching out. Now, what is a life-threatening condition? We all know that this is a condition that threatens you and is in terms of your mortality. Life-limiting condition, the way we understand it, is any condition that prevents you from engaging fully with life, whether it's in the form of your day-to-day activities, being carried out independently, whether it is being able to engage with people around you or with with professional spaces. And I'd like to highlight here that, in my opinion, a lot of the life-limiting conditions, the limitations are not of the people, it's how we as a society meet them. So if we make a place inaccessible for somebody, or by way of not providing what it is that they might need to bridge those gaps, then it's actually a societal issue, not so much a condition being life limiting in and of itself. So that's just a perspective that I wanted to put in there. To answer the second part of your question, how can palliative care help? Again, I'll go back to the fact that in countries like India, palliative care is more of a social intervention, not just a medical one. And therefore, the way we practice it, what we now refer to as serious health-related suffering or serious illness-related suffering, whichever way you want to spin it. In our context, the illness of one person has a humongous impact on not just the people in his or her family, but also on the generations to come. So financial, I think that's Roop announcing himself. So by way of financial toxicity, we know we've talked about this before. 55 million Indians are pushed below the poverty line annually because of out-of-pocket expenditure. 38 million because of cost of medicine and so on and so forth. So how does palliative care help? We don't just see the patient as someone who is a repository of disease, but we also address the family as a unit of care and find ways in which we can alleviate the suffering that is brought about by a particular disease diagnosis. So if someone has been diagnosed with cancer, for instance, and the treatment is unaffordable, very often, and this is an example I quote fairly frequently, is that you see a number of children being pulled out of school because that tuition money is then reallocated towards treatment cost. Now, either by way of directly facilitating educational support, which is something that we at Pallium India do, or tying up with organizations to direct them towards these children who are now at at risk of losing their education. That is also part of what is required in order to help that family deal with the suffering that they're encountering. I have been asked, especially by Western colleagues, is this palliative care? And if we define palliative care as something that aims to relieve suffering that is caused by, because of health-related issues, in my opinion, yes, very much so. And that is why the interdisciplinary team in palliative care is so important. It plays a vital role because not only therapists, we also have social workers, we have volunteers in the community. And it is really, I think, a microcosm of how ideally a community should operate. We're all here to, in a sense, walk each other home, right? Yeah.
So thanks, Smriti, for that. It's a common misconception again that palliative care is only started when somebody reaches the last days. But palliative care is about any suffering which comes with disease, whether it's economical suffering, or emotional suffering, or physical suffering. So thank you for bringing out that so clearly. I'll go to Rajani next. We often, when we think about end of life and when we think about suffering, thanks to the whole movies and cinema, now we often think of people in ICU in one corner of the hospital, covered with pipes and tubes and machines. So what is end of life care like? Can it be done at home, or does it only require ICU admission and hospital care? You're on mute.
Yeah, thanks, Parth, for that question. I'm struck by how you said that it's how we see in movies, and movies have framed so much of our understanding of how we in modern society view the end of life. So there's two things that we end up seeing wrong in movies. One is that, yes, of course, people will end up spending their last moments in an ICU with a ventilator with tubes, or that they will be magically revived by CPR. And both are not always the case, right? So very rarely is it that somebody has a very serious life-limiting condition, or in our society these days it's rarely just one life-limiting condition. People have multiple diseases. You have somebody with heart disease and kidney and diabetes and something else, and now they're critically ill. In that situation, it's not very often that if they reach the point where it's a life-threatening situation and their heartbeat stops, that they will be revived to a good quality of life. And I think from Smriti's words earlier, it's quite clear that what we're looking for is a good quality of life. In a life-limiting illness, when we think about the fact that the majority of people will not die of a sudden event, um, prognosis is something that is known that we can anticipate in the course of the disease. So, if this is known that somebody's condition is gradually deteriorating and the conversation starts earlier and the needs of the patients and the caregivers are assessed earlier, there's no reason why someone with a life limiting illness cannot spend the last of their days at home if that is their wish. So, even a person with a life threatening condition, depending on the patient's wishes and the caregiver's needs, can be taken care of either at home or in the hospital or in a hospice. So, the choice really depends, it really should be a matter of choice for the patients and caregivers. If we have an idea of what the patient's wishes are, if we know that there is no medical intervention that can help them, and any medical intervention now would be non beneficial and add to the burden, physical burden as well as financial burden, it is possible for us to plan the end of life care at home with good, supportive palliative nursing care, training the caregivers on how to take care of the patient and support them, prepare them for the when the active phase of dying comes. However, if the patient's nursing care needs are pretty significant, or if the caregiver feels inadequate and requests our help, we do uh, we do arrange for comfort care and end of life care in hospitals as well. And this would not be in the type of situation where they're in an ICU away from their families, but in a regular ward where they have the increased access for family members, any spiritual practices that might give them comfort, make sure that their symptoms are well controlled, and sensitize the entire care team to the fact that we are just helping walk someone home, as Priti said. The other option that comes up in life limiting illnesses is something called respite care, where sometimes these diseases go on for a very long period of time. If you have a neurological condition or a chronic lung condition, you might be sick with significant impairment in your quality of life for 5 years, 8 years even. You might be dependent on certain machines and tubes even at home, and these a caregiver can be trained to do. Now that places a fair burden on the caregivers, and sometimes it's just exhausting. So hospitals will also take in patients for respite admissions when the care needs become a little too much, saying, let's come in for 4 or 5 days. It gives the caregiver a break. They get supported, they get retrained as well. So all these options are possible. End of life in a hospital, in a hospice, or at home, depending on what the condition is, depending on the financial situation of the patient, depending on the nursing care needs and the caregiver's abilities to manage it.
Thanks, Rajni, for that. I mean, I've been working in the community and seeing all these patients, and I often see that patient relatives are the ones who know best about the patient and the disease, and often they take decent care at home. But there's another paper which came out yesterday which showed that when patient relatives are actually given proper training to take care of the patient and the sickness, it significantly reduces hospital admissions. Now, this is something which,
if I may just add on to that, very often what happens is the patient's relatives are not given the choice, or even as medical professionals, we may not be aware of all the different home care services in our cities and surroundings. It may not be in our own hospital that it's available. I'm very fortunate to be working in a hospital which has long-term care rehabilitation, which has a home care arm to the services we offer, but not every hospital does. Therefore, it becomes our responsibility as doctors who are taking care of patients with chronic life limiting illnesses to connect with all the community services that are available in our neighborhoods and be able to recommend that for our patients.
So just continuing with that, there is a directory which Pallium India maintains, which is there on Pallium India's website. You can go to that website, look at the directory. If you're looking for anybody who could help with home-based palliative care, you will find some help in that directory close to your home. I'll move on to Dr. Roop. I don't know if Dr. Roop has reached home. Are you there, Dr. Roop?
Yeah.
Okay.
But I haven't reached home. So, but I can speak from the car.
Okay, as long as you're driving safely. We don't want another end of life care to happen while we are on the seminar.
The traffic is just too slow for that.
Bad joke. But to ask you, what is advanced care planning? Now that we have talked about suffering and that suffering can be taken care at home also. So how does an advanced care plan now eventually help? And what is an advanced care plan and what Advance Medical Directive? Okay, if you can shed some light on that.
Yeah, so advanced care planning is a broader process by which you put together your thoughts, wishes, values, goals, all together into how you would want to be taken care of towards the later stages of life, not necessarily completely at the end of life. But together with that, you also need, and this is something that many people, even doctors, don't realize, is that you need to have identified somebody who will make sure that your wishes, your ideas, whatever your thoughts are, they actually are carried out. It may be that some people may just want to make sure that their wishes of not having anything done to them are implemented. Some people might need somebody who will use their discretion and make choices for them, having understood their values. But the important part of all of this, in addition to sorting out your own thoughts, to identify the person who will help implement that. And we call this the healthcare power of attorney. Typically, it should be not just the responsibility of one person, it should be at least about 3. They are not supposed to act as a committee. It's basically one person's responsibility. But you put them in sequence so that if one is not available, then the next and then the next. So these are the components of what we call the Advance Medical Directive. So the first is your wishes about the kind of care and treatment that you would want when you are no longer able to speak for yourself. Because if you can speak for yourself, then there is no question. I mean, you decide what you want and what you want. But when you cannot speak for yourself, then you need to have this, your wishes, ideally in a document, which then can be followed on. And second, you need someone who can do that following. Right?
Yeah. Yeah, thank you, Dr. Roop, for very briefly explaining what an advanced care plan is. Dhani, coming to you, recently, this whole discussion around advanced care plan and Advance Medical Directive has gained attention from the media as well, thanks to the Supreme Court case. But can you shed some light on that? What's happening in the Supreme Court? Why did the things have to go to Supreme Court? And just tell us a bit about this whole story.
So the most recent case that has caught the media attention is the case of a patient who has been in a persistent or permanent, I think is the more appropriate terminology, vegetative state for the last 11 years. The case came to light because the parents petitioned the Delhi High Court requesting that. The way in which it's been reported in the media is that the parents requested euthanasia, passive euthanasia, and this is where the problem arises. And I know that my, co-panelists will talk about this as well in more detail, but this is part of the reason why the law has become so confused and muddled, because the facts of the case were that this patient had clinically assisted nutrition and hydration through a peg tube, as far as I understand from the facts of the case. And when the parents requested this withdrawal of life-sustaining treatment, actually they didn't even request that. They initially requested that the case be referred to a board of medical experts who would decide whether this kind of treatment, this life-sustaining support, should be withdrawn in this case. And this is because the Supreme Court judgment of 2018, which was modified in 2023, lays down a procedure for withholding and withdrawal. So now every time you have to decide whether a case merits withholding or withdrawal, and it involves a case where the patient in question doesn't have decision-making capacity. There is a process that the court has laid down. The first, the step there is that a board of medical experts decides whether the situation is one which where medical treatment is no longer beneficial to the patient and it is a fit case for withholding or withdrawal. Then this is confirmed by a board of, a second board of medical experts. And then through a process of joint decision making with the caregivers of the patient or the next of kin or the person they have nominated in their advance medical directive, one decides whether treatment can indeed be withheld or withdrawn. So, in this case, the request from the parents was primarily this, that please refer this to a medical board that can make this determination. But given the manner in which the petition was framed, because there were also references to the grave emotional, physical, financial burden that the caregivers had while looking after their son and their brother, respectively. The court was obviously inclined to view this as it's alarming when you say that you want to withdraw treatment because you can't afford it or it's becoming burdensome. And so, what happened in this case is that the court, instead of deciding on the legal principle in question, which is, does withdrawal of a PEG tube constitute withdrawal of life sustaining treatment, or is this a fit case where the process that the Supreme Court had laid down in 2018 should be applied, decided to dispense justice in a humanitarian way. It wanted to find a solution to the problem. And therefore, what ultimately happened in this case is that the government was asked to come up with a plan for the care of the patient. They offered some options to the family. The family, currently agreed to that in court, and the matter was disposed of. So, but the way in which it was portrayed in the media and why it gained attention was the fact that one, it was portrayed as the parents asking for euthanasia, which it is not. They were not asking for their son to be killed in any shape or form. And second, it was the court itself made oral observations that were not quite medically accurate, in that they said that, actually, the patient is not on any mechanical support, is not being sustained with any external aid. And so then there's no question of passive euthanasia in these circumstances. So these were some of the issues that were at play most recently.
And just to quickly follow up on that, would an advance care plan have helped in this specific case?
So I don't know yes, I'm sure it would have if doctors were also trained to understand and implement that kind of plan at the time at which the original injury took place. I think this was an accident where the patient fell from the fourth story of his hostel and was permanently injured. And yes, in that, as you know, as we were discussing just before this started, if doctors and patients are on the same page and understand when treatment should or should not be provided, which they can record usefully through an advanced care plan, then yes, these kinds of situations can be averted. But I feel like this is a particularly, cases of the PVS are particularly complex questions, and it may be the case that even with an advanced care plan, you may have wanted the security of legal sanction and going to court and ensuring that everything was above board.
Urvita, I'll come to you next. You have taken care of a close one as and have experience as a caregiver, and especially with an advanced care plan. Where did you learn about advanced care plan? Because not many people in India know about it. And how did you make one? Could you tell us about that?
Sure. Thanks, Parth, and thanks for having me here. Just like Smriti, I think I'd agree to disagree that this is definitely an exciting topic. And I'm not saying this from a perspective of a researcher, but as someone who has gone through this process in the past. So for me to respond to your question, for me to create the Advance Medical Directive with my mother was difficult but necessary. I saw that it provided a very formal mechanism through which we could articulate her preferences And we definitely saw it as a process of translating the very abstract right to death with dignity into something more concrete to help realize that right. So we initiated the process a few months after her diagnosis. She was diagnosed with an extremely aggressive form of cancer. And though we'd already started having conversations about her values and what mattered most to her, this was something that we formally started working on only a bit later. So initially, after those conversations with her, it involved speaking to friends, colleagues, and palliative care experts in the field, reading up more about the scenario in India, and then drafting it, which I took responsibility for. And I also had the fortune of having that reviewed by palliative care experts or doctors who were familiar with it. Um, we ran with that AMD. The first time we had discussed it with a doctor, he was pleasantly shocked. And he very willingly agreed to honor it. And because of this, we were told not to pursue the next formal steps that you would typically follow of having it attested by a notary or gazetted officer, nor did we have to countersign it by a magistrate. So I think although I was prompted about the value of AMDs through my work in mental health and colleagues who had been doing extensive work in this area in the context of mental health, I think the person who mattered the most and who had prepared me for it was my mother. We had already begun having conversations around death and dying much before even cancer was a part of our lives. And I think those conversations were definitely a great starting point, which provided a roadmap of sorts on how we could navigate that year during our diagnosis and treatment. I just also wanted to highlight two more things. One was that in my mother's case, she was able to decide what her preferred course of medical treatment, including a removal of life support, would be. What would that look like? But I must admit that is not always known. I think medical treatments, even before they're started or as they go along, are not necessarily broken down for patients and their caregivers. So there was a lot of scrambling that we had to do as a family to make sense of what was offered. And with her treating doctors, the team, the friends, and colleagues, we were able to then make sense of it. So, what this meant was we needed to have a constant conversation with my mother, even though we had drafted the Advance Directive, which is not a static document, to understand how she felt about certain treatment options being offered. And finally, I just wanted to end with contextualizing my mother a bit more, which is to say that my mother was definitely articulate about her preferences. She came from a privileged background. She had a large and loving family system and support, and she had access to really good quality care. I would often think about what would happen if these factors were not present. And learning from how things pan out in public mental health systems in India, I'm quite certain that it wouldn't have been an easy journey.
Thanks, Udvita, for sharing that. But I would just like to zoom out a bit, and because in our culture, it's very scary to talk about death. My parents are not on this call right now, even though they should have been. But when I asked my friend also whether should I forward this to your parents, and he was like, "Are you stupid? Why do you want to send it to my parents?" Because my mother, when I talk to her about death and dying, she gets really scared and she doesn't want to talk about it. And so I'll come to Dr. Roop now, who has studied advanced care planning across different countries. How are things abroad, and how are they so different from India? And if you could just tell us a bit about that. I think, okay, Dr. Roop has left the call, I think. He has reached home. So I'll go to, no, he's there. 1 second.
Yeah, I'm here.
Okay, yeah.
So I think the whole thing is that when people are explained this bit about what advanced care planning is about and how it is supposed to work, it's not necessarily focused only on death and dying, then people do accept it. So there have been multiple studies. I mean, typically, almost anyone who gets involved in this for the first starts off by claiming Indian exceptionalism. We Indians are different, right? That we hear all the time. Mm-hmm. Except that when you figure this out, we aren't. We are the same as everybody else. And wherever it is, advanced care planning has been implemented, it does require a certain period of education. So we look on uh, the whole business of advanced care planning as death literacy. And in fact, you have to look on it as a public health issue, which has a very strong educational component. You have to work on it as a campaign. You have to change people's attitudes, and there has been a fair amount of uh, stuff said, but I'm not sure people understand why and how uh, death became a taboo, which is very funny because just across a little to the north and east of us in Tibet, Tibetan Buddhism is supposed to discuss death and dying, right? And they don't have higher mortality rates than us. So yeah, so this whole business about don't talk about death because that's what Yamdut will come visiting you next. My friend Devdutt Patnaik has a theory. He says that somewhere down the line, it was not. It's not fear of death. I mean, fear of death is there, but in India, in Hinduism specifically, it became uh, mm, mm, a kind of corruption to let anything to do with death and dying anywhere in and around you. It became, for want of a better word, uh, an untouchable issue. And he, in fact, thinks that the beginning of the caste system was by identifying castes that dealt with death and dying. So, multiple layers to it, but whatever it is, in Indian traditions, it is taboo to discuss death. And if we are to get anywhere, we'll have to start by challenging that. Fear of dying is always there. I mean, but typically, whenever I have this kind of lecture on advanced care planning, I find that there will always be about 15 to 20% of people who will not want to be part of it. A good number of people, I think probably somewhere between 30 to 50% do want to take charge. Another 30, 40% probably would prefer somebody else to take these decisions. But there's a number who will absolutely don't want to be involved here. Does it change with education? There is some literature that suggests that happens. We don't have any from India itself, but we do have studies from Malaysia. There's a study from Lebanon, so you can probably extrapolate from that. But more importantly, the Indian diaspora in the West, including people who've just moved and so on, seem to be fairly receptive to it. So it's not as though this whole bit about Indian exceptionalism can be. We need to work at it.
So we are not talking about it, but it is possible to talk about it. And I think one positive highlight is that today there were 8 people in the waiting room from 6 p.m., even though we decided to start at 6:30 p.m. So there are some people who want to talk about death and dying, which is a good sign for us.
Or to hear about it.
Yeah. My next question is from Sruti, and this is more of a question that I personally want to ask is how do I make my parents talk about death? How do I start this conversation at home? And how does anybody start this conversation at home? So I've been going at homes of people, and for me as a doctor to tell them about this is easy, right? When I ask them that you are so sick, when I visit patients with life-limiting illnesses, and I ask them, would you like to go on a ventilator if you become very, very sick? And most of them will hold their hands like this, say, "Mujhe maaf karo." And then I'll ask the son, did you know about this? Did you ever know that your father or your mother didn't want to go on a ventilator? And they're like, no, I never knew this. And then it's a relief on their face as well. But how do I do this at my home? Because at my home, I'm not considered to be a doctor. So for anybody
all
else,
of us.
So we start, yeah.
So yeah, well, I guess this is now with when we do these advanced care planning workshops, and I ask people how many of you have ever talked about death or dying at home, I would say if I'm lucky, about 20% of the people will raise their hands. And then I ask them, how did that happen? So now, I think also, especially after COVID, people have become a little bit more attuned to, the suffering around them. Now, typically what happens is, even if you, in families, you'll hear, acha, wo Sharma uncle के बेटे को क्या हुआ था, accident हो गया था, बेचारा बीमार था, he was in the ICU for so many days. And then, so people are always having these conversations. I mean, a good way to probably, that is an entry point as far as I'm concerned. This is what happened to our neighbor. Is that something you think, we'd want for ourselves? And usually there's those kind of trigger events happening to somebody else is a good entry point to start that. Or even just, if it's like a diagnosis in the family, that is probably a good time to have that conversation. Now, of course, the flavor of the conversation will change from family to family, and who talks to whom and who's allowed to talk to whom and what authority. I mean, you could have, enough degrees to become a thermometer, but then no, you're not going to be, you're going to be considered the younger son, and you're probably not the person they want to have that conversation with. And I'll say this, and Rajni and Dr. Roop and a couple of other doctors helped me take care of my mother at home when she was dying of interstitial lung disease. And I've taught communication in palliative care for many years now. Let me tell you, it was a very difficult conversation for me to have with my mother when the time came. So in my case, what happened was, and again, I'm just by way of illustration that it can come to you at the most in the most strange ways. Her blood pressure had dropped very, she had a very, very bad case of low BP. She had spiked downwards. She was unconscious. We had her on, on an IV line and this, that, and she sort of recovered after a couple of days. And she said to me, "Baby, I had this dream." And I said, "What dream did you have?" And she said, Nani was calling me. And my Nani's been dead for over 20 years. And I said, and what else? And she said, my older sister was also there, and they were both sort of beckoning to me. And I said, okay. And I realized that this was my moment and I had to take it. So I said, what were they saying? What do you think they were saying? So she said, I think they're calling me. I think my time is coming. And as a daughter, the first thing that came up in me was, shut this conversation down. But then I sort of bit the bullet and I said, and how do you feel about that? And that's when she said, I don't want to go like how Nana died, because my grandmother also had, she had acute breathlessness and stuff. And that allowed me to then ask her, so what's different this time between when Nana was sick and now you? And she said, well, now we've got all these lovely doctors on the phone. We've got the oxygen concentrator at home. I have access to medicine. I said, so you're not going to have that kind of a death. And then I said, but do you want to go to the hospital? And she said, what will they do to me in the hospital? And I explained it to her. Rajni has explained things to her. And that's how we came to the decision that we wouldn't do it. So what I'm trying to say is that these are not easy conversations. You know your family's best, but sometimes that moment presents itself to you and you've got to grab it. There is something though called, for those of you who want something more systematic, there is something called the Conversation Project. It was developed in the US. Some of us are working to contextualize it to India. So a lot of it you might find that it's quite Western in its approach. But they give you very succinct ways in which you can have this conversation. And it applies to both adults and to children. So those of you who are unsure of where to begin, it even starts with, how ready are you to think about it yourself? And where do you want to have the conversation? Around the kitchen table, when you go out on a walk? So it makes you imagine all these scenarios. And I think this is a very, very helpful tool. And I definitely recommend going through that. It is very well presented and it'll give you a lot of food for thought on how you can have these conversations within your own families.
Thanks, Nati. So I think the right time, the right person, and the right entry point would help people in starting these conversations at home. And as a community physician, when I was listening to you, I was wondering, is this something which is accessible only to the elite, only to that privileged 1% of the country? But, this would have been my thought. and probably my belief that only the rich can afford a good life and good end. But I've been visiting homes of people for the past 2 months, people who are dying. And as a community medicine physician, I can take care of them, and I've seen that you can make their life easier. So if there's any community medicine person listening to us today, it is possible to do this at home. I remember there was Bhatia ji that I met in my first year of college, and he was at home. And the first day I met him, he told me कि मैं तो मौत का इंतजार कर रहा हूँ. I'm just waiting to die. And all I had to do was visit Bhatia ji once a month. That's all I had to do. Just explain his medicines to him, bring him some medicines, just meet him, crack few jokes with him. And then his statement changed to, now I look forward to meeting you. And slowly we started that conversation of his dying. I started that conversation with his son, with his wife, and he died at home ultimately. And he had a funeral. His family was all right. They didn't react to the death as bad as they possibly could have if they had taken him to the hospital, if he had been in the ICU, suffered there. But I mean, this is possible even at home as community physicians, as primary care doctors. I think we should take the lead on this. Just wanted to put that out there. That yeah.
And one more thing, which I missed also, and Aparna has highlighted. We have to remember it's a series of conversations.
Yeah.
It's not a conversation that we'll have and done, be done and dusted. And also depending on the comfort levels that people have, we might have to revisit it. Just like, children revisit something as their developmental stages progress. I mean, similarly, yeah. So it's important for us to be able to revisit those conversations and allow for the person to change their mind as well. That's something that's really important too. So thank you, Aparna, for flagging that. Yes.
My next question is for Rajni. When we make an advanced care plan, our main aim is to take people away from that futile intervention, which can possibly cause discomfort and contribute to suffering. So how is it? Are there some pros and cons of only ward-based care or only home-based care? Because often when I talk to people about advanced care planning, they say it's equivalent to giving up on the person. So, I mean, how do you approach that? You're on mute.
So, such wonderful points that have been brought up by everybody else, and I'll try and elaborate on what you asked me about the pros and cons with a couple of examples, and also, wanted to address a few points that were raised earlier. When we look at the pros and cons of hospital or ward-based care in a person with a life-limiting illness who's going through an acute emergency, which could be a life-threatening crisis, or home-based care. As I mentioned earlier, we're looking at the values of that person and their wishes about being at home, and also the care needs that they have. If it's very, very high and it becomes a burden on the caregiver, then we tend to lean towards having the assistance of the hospital facility, the nursing staff, and someone who can be the calm in the chaos for them. Sometimes that's too much of a burden for a caregiver. They're going through a lot of emotions. They've been doing it for a long time. They'll be second guessing themselves. Am I doing the best for my loved one or not? So as Smriti said, we have to be fluid with it. We have a general idea of what the advanced care plan is. We have a general idea of the wishes of the person. And we try to honor that, but we are ready to be agile and shifting to the needs of the situation. Roop mentioned something about, us being a death-denying, death-fearing society, and all the things about, if we speak about death, we'll bring it on, we'll call it, invite it early. Like Smriti, I too have had the experience of taking care of my father towards the end of his life. And I think I saw my mother on the call a little while back while she was logging in. So I've been very fortunate to have conversations with my parents about about their aging and their illnesses. For me, it came about because I worked in pulmonary and critical care medicine. So sometimes they could see it on my face that I'm carrying a burden when I come home, and they would ask me to speak about it. And invariably, it would be about someone who died in a bad way in an ICU when it was not a salvageable situation with unnecessary interventions. If we knew we had done the right thing, then even if someone dies, there is a comfort in knowing you did the best for someone. Right? So intensive care, ventilators, I want it to be known that these are not always futile interventions. They're very, very beneficial. but we select the patient and we have a realistic expectation and we can keep readjusting that. So that's the kind of conversation I had with my father when he was diagnosed with an advanced progressive neurological disease, right? He had multiple system atrophy with Parkinson's. He had been a heart patient for more than 40, 50 years of his life at this point, had lived a very rich life. We've had repeated conversations with every hospitalization. So where do we stand now and how are things going? And you recalibrate with that. And what we had settled on was that we would be okay with having a ceiling of care where he was very clear he didn't want ventilators and dialysis at his age. He was okay with a time limited ICU trial, saying, let's give it 2-3 days. If I can turn around with non invasive ventilation and good medications and things like that. So he was like, as much time as I have, I decide my quality of life. To him, it was a non-negotiable that speech and swallowing and eating food was something that he wanted to do without the assistance of tubes and things. So he had set those things in his advanced care plan for me. An acute emergency plan meant, yes, it is okay to go to the emergency room. Yes, it is okay to go to the ICU for 2 days, as long as it's all non-invasive. If I am not getting better, bring me back home. I'd like to die at home. Very recently, I had the reverse situation happen with a 94-year-old brilliant scholar who was very clear. She was in end-stage heart failure. She was very clear that she did not want any repeated hospitalizations. But when the time came, it was very difficult for her elderly husband, who was 97, and her young granddaughter to manage the end-of-life symptom management at home. So we brought her to the hospital and made sure she was as comfortable as she could be. So as you can see, you have plans, but you may be able to change things around. You have to be open to that, of changing things around for that. One of the biggest challenges we are facing these days, Parth, is that, the social structure has changed in India. There are more nuclear families now. You mentioned about, is it accessible? Is it something that's only available to the elite and the educated? In rural families, joint families, larger families, people have witnessed death a little more from the older generation. So a young person may have witnessed a grandparent's death, which could have been peaceful, which could have been a hospital-based scenario. They might have witnessed the death of a pet. So it isn't as much taboo and it isn't as shocking as it is in a city. Sometimes I have people who are caregivers who are in their 50s who have never witnessed death. And for them, witnessing their parents' illness is the first time they are confronting mortality. And there's a lot of fear associated with it. So here, when I'm looking at the pros and cons of hospital versus home, I take the patient's conditions and nursing needs, and I also look at the caregiver's needs. Right? It has to be something where I'm supporting both the patient and the caregiver. We want to create a situation where everything that can be done to reverse what is reversible, treat what is treatable, as long as quality of life is maintained, is done. But when it comes to the point that any intervention would be non-beneficial, then there is comfort for the patient and there is comfort for the caregiver and support for the caregiver as well. If we are able to arrange that at home, that's great if that's what the patient wants. If we are not, then it's perfectly okay to bring them in for a few days. So those are the factors I consider, and both are perfectly okay. As you said, you've now lived in you've been working as a community physician. You find sometimes that acceptance is greater in some communities for death at home. Some communities will want to take the patient to the hospital because they also want it to be seen and shown to others that we did the best for our loved one. There's so many factors at play. In our cities, we also have a situation where children may be in another city and they may need 24 hours to come and be with their loved one. In that case, we can do again a time limited trial of being in the ICU to support with a ceiling of care. So the whole goal is to support the patient and family as best as we can with their requests for what the quality of life and quality of death should be.
Thanks, Ajni, for beautifully explaining that. So, I mean, that again highlights the importance of the conversation at home, which has to happen again and again to understand what the person actually wants. Coming to the main question of this entire event, how to make an advanced care plan. Dhoni, if you can just tell us step 1, step 2, step 3, and to make things easier. And we'll also follow this up with an article on Nivarana, which will document all of this, all these steps with all the useful links that you will need. But Dhani, over to you now.
Sure, thank you. And I think what Rajni's conversation just demonstrated is that an advanced care plan is different from an advanced medical directive. And an advanced care plan will allow you this kind of recalibration, this nuance, this constant revisiting and updating in a way that an advanced medical directive will not be able to with such specificity and detail. So I think we've already talked about how important it is to first discuss these goals of care with your loved ones and your treating team and keep revisiting them, and that has, I think, in our current scenario, perhaps an even greater value than actually executing your advanced medical directive. But having said that, and everyone wants the assurance of a legal document. For that, an advanced medical directive at least will, as Dr. Roop said earlier, it will, one, be a statement that expresses your values, wishes, and preferences, that can give a broad direction to your treating team as well as your loved ones when end of life care decisions have to be taken. And two, it will allow you to nominate a person who you trust, person or persons actually, to take these decisions on your behalf. So step one is, of course, having that conversation first. So irrespective of how you execute it and what form it takes, is first understand what you're getting into. Have that conversation with the people you're not going to nominate, your other loved ones, your family physician if you have one, and then begin the process of drafting it. Now, there are templates that are available online. These can be customized as you wish. But broadly speaking, the elements of an advanced medical directive are a statement from you that you have the capacity to understand the decision that you are about to take. And then, you are, the legal term for that is sound mind, but we don't have to use it in that sense. Two, that you express fairly clearly what are the kinds of treatment that you wish to refuse when a particular situation arises. And you can be as broad or general about that as you like. You can just say that I don't want any life sustaining intervention when I become terminally ill. Or you can say that when I lose a certain quality of life that I deem acceptable, I don't want to be on dialysis. I don't want to receive intravenous antibiotics. I don't want to receive ventilation. You can choose which treatments you wish to receive or not receive. And the third and the most important is that in order of preference, you specify at least two, if not more, persons who will be available and can be contacted by your treating team at the time at which a decision has to be made about you when you have lost your decision making capacity. So again, this is the most important thing to remember about the directive, that it is intended to apply only when you are no longer able to take and express those decisions yourself. Otherwise, that conversation, in accordance with your goals of care, your advanced care plan, will continue with your treating team and your loved ones. So that is about the content of the directive, and the actual execution of it involves two signatures by witnesses, preferably not the people who you have nominated as your healthcare representatives or the people who will take a decision on your behalf. And then currently the court requires you to have it attested either by a notary public or by a gazetted officer. Most of us have used notaries for various kinds of documentation purposes. Sometimes, it's not that easy always to know where to find a notary. And again, lawyers can help with that. But gazetted officers in particular are perhaps more easily accessible. They will vary from state to state. In fact, this is not something I have applied my mind to enough. And I feel like, as part of our general forum and coalition on advanced care planning, we should think about creating a state-wise repository of gazetted officers and how they can be contacted. It might actually make the process of getting your will executed much easier. The last step is that you share copies of this with, preferably again, with your the people you have nominated as your healthcare powers of attorney. And there is not a requirement in the sense that it will make your directive invalid, but it is suggested that you send a copy to your local authority, so your municipal corporation or panchayat or municipal council. This is ultimately intended as a way for doctors to be able to verify the genuineness and authenticity of your directive, but the mechanics of how this will work have not yet been laid down by anyone. I think perhaps except Goa. So there is still some work to be done at the local government level, at the state government level, to ensure that the system of authentication, which is practical, can work. But yeah, I mean, ideally, if you're making a directive, send across your local authority is supposed to nominate someone who will be the custodian of your directive. This has been done now in Maharashtra thanks to a PIL, and I think it's been done in Goa as well. But if you don't, if your local authority hasn't done that, you can just write a letter to the head of that authority with a copy of your will. We actually do have a draft of the letter if anyone wants to use that to send across their living will.
Thanks, Tony. We have an email ID as well, advancecareplanindia@gmail.com. If anybody wants to reach out to us or ask any doubts, you can always send us an email. Just to quickly address Dr. Kalantri's comment in the chat box that, this seems like an elite concept. But again, even I believed that 2 months ago. But again, I've visited 50 patients at home, spoken more than 1 hour with each of them. And at the end of it, when I asked them, this is what the Supreme Court has said. Would you want a living will for yourself? They say, yes, I want it. Now it becomes my responsibility to get them that, which I will eventually do. With Vidhi and Nivarana and all of us are working on a booklet, which will help them start this conversation at home, create a living will for themselves. And like Urvita benefited from one living will, which was not notarized, but still helped her. It's still possible in the cases in the community, and we can still get it notarized. I mean, I can't believe that you can't find a lawyer which won't help you to notarize these things. I mean, you definitely will if you look for one. So it is possible, because usually I tell them it will help you in saving money, because we know how our health system is, the private health system, which just tries to push you into the ICU as soon as possible. Not all of it, but the majority of it. I tell them it will save you from suffering, and I tell them you can be with your family in your final days. And as soon as they hear these 3 things, they're like, I want this document. And we can help them get this. So I don't agree that this is an elitist concept. It becomes our responsibility to make sure this is equitable. Final question for Urvita. How would have things been if you didn't have that advance care plan from your mother? And how did you benefit from it? Can you shed some light on that?
Sure, Parth. So I saw that the Advance Medical Directive was a very vital tool that provided clarity and direction during our caregiving process. I think everyone over here would agree that caring for a loved one who's experiencing condition like cancer can be an extremely emotional and challenging experience. Right from the grief to the guilt to the anxiety, the exhaustion, the sleepless, the lack of sleep, etc. So I saw its utility in 2 specific scenarios, definitely, and of course in many others as well. One was when my mother had an adverse reaction to a new targeted chemotherapy, and another was just a few days before she passed away, where she died at home. We had the fortune of arranging that for her. So what I felt it helped with was it eased out the decision making. It, as I was saying earlier, provided a roadmap when things got a bit more challenging, especially in the days leading to her death. I also felt at that point of time, I'm so grateful that we had those conversations well in advance. I felt that there was also a very positive response from the treating doctors. So I felt that it also lifted a sense of burden, not only from us, but also from the medical team that was treating her. And most importantly, despite being a roller coaster of a journey, I remember my mother being mighty pleased in the first scenario when she had that adverse reaction. And when we were discussing what she would like to do and how she would like to actualize her advanced care directive. I felt that she definitely felt comfortable with the idea that her wishes are being acknowledged and formalized through the Advance Medical Directive. And she also had that sense of relief that she will not unnecessarily suffer just because we would have loved for her to stay back in life with all of us. Not having an advance directive, I think back in 21, of conversations around it, I feel would have created a massive gap in the care and support that we managed for my mother. I personally feel that you wouldn't want to be spending your last days in situations where competing interests override yours. And despite those competing interests being interests that come from a very good place and a good heart, like with my family members. So my views about dying is that it can be a liberating and positive experience if you're allowed to have that autonomy and freedom to dictate what it means to you. And I personally don't think I would have been able to cope how I have coped with my mother's loss since she passed away if we were unable to safeguard her ability to dictate those decisions, especially in that year.
Thanks a lot, Purvita. And I'm sure this conversation was quite enlightening for a lot of us. I mean, I've been working along with you all for advanced care planning, but a lot of new things which I've heard today. And I'm definitely going to push my parents at the right time, at the right place, at the right entry point to have this conversation and create an advanced care plan. Coming to the final question, which is for all of you, what would be a one take-home message for people who are listening to us today? Starting with Dhoni.
I think it'll be don't let the law scare you away from doing this. It can be intimidating, it can be daunting, but this issue is only secondarily about the law. It's primarily about all the things that everyone else on this panel has talked about first. And as far if it's about the procedural part of it, don't worry, we'll help you with that. So, and there are resources to help you with that. So don't let that be a barrier.
Rajni, you next.
So I think my take-home message for this session is start having the conversations in any opportunity that you find. And when that opportunity presents itself, I think the first part of it is to be comfortable with the questions ourselves. So maybe the first part is a conversation with yourself to see what you think you would want, and then try to understand what your loved one who's going through a life-limiting illness might want, and if that makes sense. As Urvita said, our wish is for our parents to be with us forever. But when we recognize that our wanting them with us is actually leading to their suffering being prolonged, and that they have expressed their wish, it really frees us up. Now, I think one part that's been, what Dhwani said also, about not letting the law scare you. This is in situations where there is conflict that the document really helps the doctors to know that we acted in the best interest of the patient as per the patient's wishes. So when everyone is in unison, in consensus, there's really no problem. But in some situations, I come across situations in a family sometimes where I'm taking care of someone and one child is like saying that, no, we need to try further. And one child is like, mom or dad doesn't want this. And then that's the kind of situation where the Advance Medical Directive really helps us as a doctor to sit down with the child who's saying, do more for my parent, that, this is non-beneficial any further. This is as per your parents' wishes. It helps us to counsel that the anticipatory grief that that child is going through. The second thing that happens is also to have emergency plans in place. So as much as we have advanced medical directives in place, any of us who are caregivers to people who are living with a chronic debilitating illness and might suddenly fall sick with a life-threatening condition, it's best to have plans. Like I had plans with my sister that in case I am not available, what's your first phone call? What's your first line of action? Who are the people who are going to come? So having that action plan within your own home and community, because it's one of the scariest things that happens. If you're in a panic, then you're not able to be present with your loved one who is spending their last few breaths and heartbeats with you. So when the conversation's been had, you are able to be fully present with your loved one as a caregiver as well. And know that I know my next steps. I can't tell you what an honor and privilege it is at times as a doctor when I'm called in to say, will you come and sit with me and hold my hand and my mother's hand as her heartbeat slows down? It's one of the most sacred moments that you can be invited into. And as caregivers, we are given that task to make sure that we bring our calm to a moment which could be a crisis, but we can bring our calm to that moment if we've planned for it well.
Thanks, Rajni. Dr. Roop, would you like to go next? You're on mute, Dr. Roop.
Smriti, do you want to go on first? I'll come last.
You're on mute, Smriti. Everybody unmute yourself before speaking.
5 years on Zoom. So, yeah, I mean, just following up on what Dhwani and Rajni have already said, I see a lot of, it's very easy to get caught in the weeds. I'm seeing a lot of these questions about, the notarization, the officers, the primary board, secondary board. Those are down the line. Have the conversation first. And like Roop says, it's always always too early until it's too late. So let's first have the conversation, and this is a fluid issue. I'd just like to highlight that as well. There is no set, law in place. There's no like this is how it's going to be. Things are still fluid. There's a bunch of people who are working hard at making this a much easier process. So don't be overwhelmed or disgruntled by how the situation is right now. I will say, as someone who's been following this work, and now we're part of this, we have formed this advanced care planning task force. There are different disciplines of people involved in this. And the progress that we have made in the last 5 years is tremendous. So we're incrementally making progress. I'm not just 5 years. Of course, this issue has been ongoing for a while, and Dhwani and Roop and others have been so instrumental in even making this issue something that we all talk about today. But things are moving forward, so don't be disheartened. And I feel like let's try and have the conversation first, and then we'll get to the weeds part. But yeah, that's what I would say. And also,
Okay.
we've put in a email address, but also what we'll do is to all the participants, maybe we'll send out all the links that we shared today, and hopefully that you'll find useful. Yeah, thanks. Sorry, Roop.
So if you want to go last, there's Urvita also. So
yeah. So anyway, let the ladies finish.
Okay, sure.
Should I go ahead, Parth?
Yeah.
Yeah, please.
Yeah. So my take-home message would be that the end of life doesn't have to be all gloomy. It's possible to have a good death. I know that these words do not instinctively go together, but I increasingly realize its relevance during my mom's cancer journey. I understand also that dying and loss can be an incredibly difficult experience, no matter what the condition is. But there's no harm done in making it a little less difficult and making it a beautiful process through advanced planning, keeping the person who's experiencing a deterioration at the center of what you're doing, and to try to introduce whatever brings meaning to oneself and one's family while doing that. So when I look back at my mother's cancer journey, of course, I'm filled with sadness, but I'm equally also filled with happiness and contentment as well, that it was a life and year well spent and planned.
Thanks, Urvita. Yeah, Dr. Roop.
Okay, so one message, of course, I don't want to duplicate whatever everybody else has said. I think it's important to make the document for anybody on this and to take it around to your doctors. We need your help to educate the medical community. So it's only when a patient comes waving it in their faces or in the hospital seeing it, that we will actually start seeing movement. Because at the end of it, well, however much we say it's not going to be taken seriously unless, frankly, patients start kicking the medical system into action. That's one. Second is, as of now, although it's a public health initiative, and we think that this is something that the government should take on completely, there is no public agency that is doing any of this implementation. So as of now, this is something that the Indian Association of Palliative Care has taken it on itself. So it's not going to be easy for us. We have a framework by which we are trying to get this going. But if anybody wants to come in and chip in and support us and whatever else, we are very, very happy to welcome you. So you can connect either through the IAPC website or through Pallium. At least 4 of us here are members of the Indian Association of Palliative Care. Effectively, as of now, that is going to be the body that is going to work on having this implemented. Vidhi, of course, is a partner of the IAPC and so on. But please, we need everybody's support.
Thank you, Dr. Roop. I think we can take some questions from the people in the audience now. So if you'd like to ask something, please raise your hand, and then I'll ask you to unmute yourself, and then you can speak. Anybody who would like to just share their thoughts or their stories of their family members, or their own. Yeah, Johnny, please go ahead and unmute yourself.
Thank you. I'm Johnny from Indonesia. Seems Indonesia have similar problem with India. But my question is, between the hospital care and home care, some people might seeking for the intermediate. In Indonesia, we call it nursing home. But unfortunately, this kind of service is not on the government regulation. So we are still disputing this. If we want to provide this nursing home, then it has to attach to a clinic or to the health facility. The consumer should go for the home care, but the home care caregiver might not be available or difficult to handle this. Is there any advice or experience in India how to establish the legal entity of this nursing home, nursing care? Thank you.
Who would like to take that question? Legal, I heard legal, so I'll go to Tony, but yeah, Dr. Rajni, if you want to say something.
No, I mean, in India, the general legal framework on regulation of healthcare is governed by either state-specific or a central law that regulates a very wide range of clinical establishments. So anyone providing any kind of care, diagnostic, nursing, palliative, etc., would broadly come within the framework of a clinical establishment, which is the same as a hospital or a diagnostic laboratory. So currently, that is the legal framework. But even here, it's not entirely satisfactory, and there are a lot of gray areas as far as home care is concerned, or healthcare at home provided by hospital chains or an ICU at home is concerned. What the regulatory status of that is not is not clear here either.
Thank you, Ribani.
Rajni, do you wish to add something?
Yeah, so we have different kinds. Well, firstly, India, the majority of healthcare is private healthcare. We do not have government funded universal healthcare. So the idea of long-term care facilities or nursing facilities which are covered, where the costs are covered, is not there. So all of that is out-of-pocket expense. The kinds of facilities we have are acute care facilities. Home care typically, again, can be part of the state-run health systems. We have, healthcare workers who come and visit. That's not so accessible in cities, actually. It's a wider network in the rural areas. When we look at assisted living facilities or nursing facilities, these are typically where patients who have high nursing needs but cannot be taken care of at home will be. And that's, I think, the kind of nursing home facility that you are referring to. These, as Dhwani mentioned, will be covered like any clinical establishment by rules and regulations. And they're quite expensive. It's not an easy task because it's labor intensive. So we still don't have the perfect answers. The one thing that I will say is that an advanced care plan and advanced medical directives actually come in very handy for patients who are in these nursing homes or long-term care facilities, because very often their relatives are not staying with them. So having the clarity is very useful for the administrators of the nursing care facilities, for long-term care facilities, as to how to respond to an emergency. Will this patient go to an ICU or not? Who is the next of kin? What are the wishes of the patient? I think it becomes even more important to have a clear advance directive in long-term nursing care or assisted living.
Yes, Dr.
Thank you, Rajani.
I think somebody else is ahead. So
yeah, Bhaskar,
then I'll make a comment. Yeah.
Yeah, Bhaskar, you can unmute yourself.
Yeah. Thanks everyone for a very enlightening and informative session. I have two questions or comments. One is, see, I had recently experienced my 92-year-old father pass away, and we all the siblings together made the decision at the end in terms of his palliative care and withdrawing certain interventions, medical interventions. Now, as a 66-year-old, that got me thinking about when should I start creating this document, and how do I start talking about this with my children and my siblings? Because whenever I try to bring up the topic, especially my daughter and my son say, "Hey, do we really need to talk about this?" Right? So that's a big challenge I have. But at the same time, I have been looking at Google to get some templates, and I think I will take the help of some of the links that have been shared today to at least create that. And my second question is, I don't really have a family doctor, and I heard somebody say that you need to send that to a family doctor. So in the absence of that, and at this point in time, touch wood, I'm reasonably healthy and hopefully quite far away from end of life care or treatment. But then what do I do in terms of after I create the document? So
okay, yeah. So can I answer that? I think the first thing is when you create that document, you also have to identify 3 people who will be your healthcare power of attorney. I mean, they're not, as I said, they're not a committee. It's basically in sequence 1, 2, 3. So you have to start by speaking to at least those people. At least they have to understand what you want. And the way I put it is, they really don't have a choice. They have a choice, and they can say, "I'm not doing this. Let me out of here." Right? But if they are taking on that responsibility, they have to hear you out. Now, for how to start this conversation, there's a great resource. Smriti, have you shared that? The Conversation Project?
Yes.
Yeah, so the Conversation Project has enough starter lines.
Okay.
And we hope to contextualize that, make it Indianized, but that is still some way away. But you can, it's not very complicated language. Everybody can follow that. But there's one more thing that, the gentleman from, Johnny from Indonesia spoke about nursing homes and all that. Why are we forgetting the Kerala experience? In Kerala, in rural Kerala, people die far better than in any city in the country, and probably better than many parts of the world. But rural Kerala, don't go into the big cities or into a corporate hospital in one of the big cities in Kerala. It's no different from anywhere else. And Smriti, I suppose, if at all there's time, maybe we can speak about that. But I think that's something that everybody just needs to understand.
Yeah. Do we have any other questions from the audience? Yeah, sure. You can unmute yourself, ask.
Oh no, my questions, doctor answered, right? I haven't changed my raised hand. Okay. Hello.
Okay.
Sorry. Yeah.
Sure.
No, you don't. Okay.
Yeah. Anybody else who wants to ask something, or we
There
can hear
is,
Smriti talk about. Oh, we have somebody.
I'll just say, Bhaskar, I know that you're very fit and healthy, but it's always a good idea at 66 to have one family doctor who you visit once a year.
Parth, there is a question about the current situation of insurance coverage for home-based services or palliative service. I think that's an important question to answer. So
Yeah.
you
So I mean, we've been working on this. We have analyzed 27 policy documents. When I say we, it is Association for Socially Applicable Research, ASR. We have been working on these policy documents, and so far we have found only one which supports hospice care, and which is Star Health. So one of the Star Health plans covers hospice care. The rest of most of the private insurance documents actually exclude rehabilitation, rest care, and even end-stage cancer. So I mean, it's quite ambiguous. Private health insurances are not very regulated in our country, and I'm sure all of you have seen tweets online of how it's becoming like the US, where they don't really give reimbursements easily. So it's private insurances are still quite tricky, I would say, in our country. But our analysis will be completed soon, and we'll have more solid evidence to advocate for a change when it comes to private insurances. But so far, private insurance coverage for palliative care is pathetic, close to non-existent. Yeah, I'll ask Vikash Anand to unmute himself now. Vikash, we can't hear you. I think some audio issue from Vikash's end. Rajnikant, if you would go ahead and ask your question.
Hello, good evening, everyone. Can you hear me?
Yes.
Am I audible?
Yes.
I don't know. My video is not switched on. Maybe it's been switched off. That's fine. I'm a retired anesthetist. I'm a doctor from Telugu-speaking country, Telangana and Andhra Pradesh. I'm very much interested in joining this group. I'm actually a volunteer at Sparsh Hospice in Hyderabad. Been attending there for the last few months. My passion would be this Advance Medical Directives. So I'm requesting that you share the details, how to join the group or how to contribute towards this one. Maybe you can send a mail, because there'll be a lot of things I can't discuss on the phone. It's too time consuming. If you send the right people where I can get in touch with regarding this topic, the following email, because I'm registered for this particular session. Is that possible?
If you can send us an email at advancecareplanindia@gmail.com, we'll definitely reach out to you. I can share the email again in the chat box.
Okay.
Dhwani, would you want to take Bikash Anand's question? I think he has put in a question about Nepal's constitution giving only right to live, no aspects of right to die, and how the approach was in India towards this complex.
Sure, that's a great question. The Indian Supreme Court very simply has interpreted the right to life to also include the right to die with dignity. And flowing from that right and coupled with the right to autonomy and privacy comes the right to refuse life sustaining treatment and to refuse life sustaining treatment even when you don't have decision making capacity. So that is the chain through which the right to make an advanced medical directive has been ultimately derived. So the right to life has is not a bar. In fact, it's an enabler to having a right to die with dignity as well. So the jurisprudence on this is there in the Supreme Court case Common Cause versus the Union of India, and perhaps you can take a look at that. I'm happy to share a copy of that judgment with you, so that you get a sense of the kinds of arguments that were made there.
Mr. BSR, if you would like to ask your question.
Yeah, good evening. My name is Ramakrishna Mudra. I come from Mysore, working with palliative care as a volunteer with an NGO here, which was quite an enlightening discussion. I heard a couple of times Ms. Dhwani talking and Dr. Roop as well as Smriti. I felt very nice about the narration of Ms. Urvita, her personal experience in pursuing the AMD. The takeaway was discussed. I really believe that whatever we have been trying to do as far as AMD is the investment what we are making now. It is still an evolving society as well as an evolving process. And we should be thinking about the next generation who are going to take it up, this particular issue more. It will be much easier for them to take it forward. So the hurdle should not be thought of. We should be pursuing this despite hurdles. That's one point. And the second point is the initiating this particular conversation about death with parents. Many times it's definitely a very, very difficult thing, particularly when the age difference is very, very high. But I'm the youngest son for my parents. My mother was close to 90 when I was taking care of her during her last stage. And almost about 30 years younger to her, it was quite difficult to talk about that. And certain times the elderly people, they're quite obsessed with their ideas. That she has been quite independent till 88 and a half years. Now, how is that these things happen to me? I'll not be able to walk. I'm not able to be independent. So obviously, I made a small exercise myself. I made a list of people who died before her. Nearly about 33 people had died, right from 3 years to 102 years. I showed her, these are the people who have died in front of you. And her own nephew, a doctor, had to tell her that now this is not repairable. You will not be able to get back your core muscles. You will not be able to walk. So at that particular point of time, she was able to understand and accept, and things were much easier later. And adding to that, she was having this hearing impairment. Every conversation I had to write and show it to her. So this one really opened up. When we get patients who are hard of hearing, I tell all those caregivers, keep this book with you and start writing it down and showing it to them. Then the communication will be complete. So this is one interesting thing which happened in my personal life. And ultimately, the hearing to Dhwani, such an young person working for this, is very, very enjoyable. And listening to Smriti is always inspiring. And Dr. Roop, very, very innovative in his creative in his thinking. I'm happy to be in this group and working with palliative care. Thank you so much.
Thank you. Sahara, would you like to go next?
Yes, thank you all for a very, very informative panel. I learned a lot today. I'm a practicing lawyer and I have 2 living wills to work on. One of it involves a young person who's been diagnosed with stage 4 breast cancer. Now, the question I want to ask is, I've read the latest Supreme Court order of 2023, which sort of reduces or lessens the bureaucracy that's involved in preparing the Advance Medical Directive. I wanted to ask all of you whether in your experience of providing care or having witnessed or having been presented with an AMD, do you see any bureaucratic hassles in acting on the AMD with authorities or with the court system?
I'll just try and answer that question, Sahana, in terms of if I am the treating doctor directly, then there's really no difficulty at all. The challenge arises if the patient lands up at a different hospital and if there is conflict in the family. So that's when the difficulty arises. The whole reason for putting it down as a document, which is a living will, which is registered, which is, submitted and kept, is in only those situations that it comes in. When you have a family who has a consensus about the philosophy, values, quality of life that someone wants, and then you are going to the same doctor, there's really the document is just an additional thing, which is a safeguard. So this kind of situation comes in when you land up in another hospital. There's a doctor who doesn't know you, and then the person you've come with is not your own next of kin. Someone else has come. They're not able to reach you. They're not able to reach the next of kin. That's where this comes in really handy. And that's where if you had it registered and it was all done and above board, the doctor would feel confident, even not being your original treating doctor for the last 3 years, that they're doing the right thing for you. And they'd be able to justify that action. But if you're landing up with your own doctor, your own family, there's no bureaucratic hassles at all in this. It just becomes a document which is part of your medical record. That's it.
Thank you. I think if I may just add a quick note to that, I agree. I tend to agree with you. My father passed away 3 years back, and the hospital he was in, the doctors were great, and I think it also helped because of the fact that both my brother, my mom, and I were very clear that he wasn't going on a ventilator and his health deteriorated. But it just went off well. And I think back, there was no AMD at that time. I hadn't even thought about this, but it went off well because I think they were cooperating with us and informing us, and we were, I think, we also knew what we wanted. So.
So true, Sana, because the thing is that sometimes this happens to us with some of our patients in the days before the AMD. When, as a doctor who's taking care of patients with a chronic lung condition, I know that they're deteriorating. They've landed up in the ICU 2 months in a row. We have the conversation with the patient, with their family members, with their children. But maybe when we look at a city like Bangalore, one child is in one end of the city, one child is in the other end of the city. So at that point, the patient was taken to the nearest hospital. The emergency room doctor just needs to hear from me and say, listen, this has been a long conversation. I'm the primary doctor. The entire family is on board with this plan. So if they have that surety, and if that document was part of the medical record, that would just ease it out for everyone.
Thank you.
Thank you for that question. It's already 8 o'clock, and we have had one long discussion, which was quite enlightening. So thank you all for joining us today, and thank you to all the speakers for taking our time for this session. We will soon follow this up with an article on Nivarana, where we lay down all the steps with all the documents that you need to read, step 1, 2, 3, AMD 101, and we'll put all that on nivarana.org. So please follow Nivarana. There's a lot of information besides death and dying there, a lot of things that you need to know when it comes to public health in India. Our aim is to reach out to the public and bridge that gap between public and public health so we can make India better eventually. Maybe 1,000 years, 2,000 years, I don't know, but eventually. So thank you everybody for joining us today. And we'll see you again on 23rd of this month. We're having our next forum discussion on ground reality of tuberculosis. We have speakers from Rajasthan, Chhattisgarh, extremely remote parts of India. So if you're interested in understanding how we are not going to end tuberculosis in 2025, do join in and listen to us rant about tuberculosis for another 1.5 hours. Till then, have a good week, and see you all again soon. Bye. And yeah, if you have any questions, write to advancecareplanindia@gmail.com and we'll answer all your questions. It will be difficult for us to reach out to you using your email IDs in the Zoom account, but feel free to reach out to us and we definitely reply to your email. advancecareplanindia@gmail.com. Thank you once again and have a good night. Bye.
Bye.
Thanks, everyone. Bye.
Thank you.
Thank you. Good night.